So on the left hand side there is acute clot, on the right hand side, so the venous clots are different from the arterial, we all know that, and in 3 weeks there is 80% collagenization, and hence we always tell our patients that if you come early we can treat you. If you are after 4 weeks, then it becomes really hard because of this collagenization, and it's really hard to remove this clot, and then the fibrosis started. So what is the unmet need in PE for safe treatment? High acute mortality. Advanced treatment options previously relied only on thrombolytics, and with the higher risk of bleeding, although it is 2%, nobody wants to lose their known with ICH or retroperitoneal hemorrhage. Optimal treatment solution for at-risk patients would be safe and effective, both immediate improvement hemodynamics, and there should be a less chance of bleeding, and eventually it should decrease the chance of developing CTEPH. So I'll be sharing my experience with this device, which is FlowTriever system from Inari. So it's a catheter-based system and has different sizes. So these slides tell you that they have 16, 20, and 24 French catheter, and then there are discs, which is shown on the right hand side, and then they have the closure device, FlowSaver, where you can save the blood which comes out with the aspirated embolus, and then they have a dedicated sheath as well. So I'll be showing an animation. The good part about the device is the device doesn't have a capital equipment. You don't need a big machine. It's just basically a manual suction. So it's a simple device to remove large volume of clot. No capital equipment. Treats in a single session if the thrombus is large enough. Lytic free approach. And then definitely there are other advantages. So just an animation. Quickly we'll go over in a few seconds. So once you take a venous access, it's a 24 French device nowadays with, closure device availability with figure of 8. They have their own closure devices. So 24 French is not I would say a big hole into a femoral vein. You can come through IJV as well if required. So once you pass the guide wire into the pulmonary artery, the catheter is brought and close to the embolus. The dilator is removed, and the negative suction, it's a dedicated 50 cc syringe, and once the vacuum is basically released, there is a whoosh effect and the embolus is removed. If the thrombus is subacute or on the chronic side, they do have a disc which comes with the set if you want it. So it's basically like those ASD, VSD or vascular plugs, specially designed. So you park it across the thrombus and then slowly you can pull it out. It's a atraumatic disc, but yes, has to be used with caution. So coming to, does the size or the lumen size matters? So there is a study, yes. If you see from the 8 French to the 24 French, there is 9 times increase in the chance of or the aspiration flow rate. So definitely when the clot or burden is too much, the device size which has a bigger bore has an added advantage. Although there is a chance of increased blood loss, but for that you have a FlowSaver. So this is just one case I was showing to a very young lady presented in ER with all the signs of intermediate high risk PE. So we decided to go ahead with the this device. So this was almost a year ago, and then it's a very simple preparation. They have a dedicated sheath. The device, although bulky, it tracks very easily, and once you have parked your catheter into the thrombus, which is well seen on a CT angiography which you had done earlier, there's no need to take multiple runs and should be done in local anesthesia with I would say a anesthesia backup. Slowly you can see the chunk comes out with this negative suction. Similarly, you can go ahead and do it on the left hand side. So these are basically different cases, and on table you can see there are definitely changes in the parameter and the improvement. So this is not our case, but you can see the amount of embolus that can be aspirated with the catheter is huge and could be life-saving.